Welcome, everyone. It's 11:30. We have a half hour allocated, so I figure we should probably start on time and people can join as they join. Welcome, Karibuni Sana. Thank you for being here. My name is Teresa Rhodes, Director of Development for the IU Center for Global Health. Before we begin, I just wanted to take a moment and pause and acknowledge that many of us are far and wide from each other, but to acknowledge that indeed we are close in many important ways. As you know, U.S. government support is shifting and impacting many, including AMPATH, our HIV programs, and including the Legal Aid Center for Eldoret and the Amani shelter, which you'll hear more about from Jackie. The purpose of our time is simple: to clearly understand the challenges at hand, to talk a little bit about some of the actions that we're taking, and to reaffirm the resilience that has carried AMPATH for the last 35 years. Thank you for the important role you play in our shared work. Today's call is being recorded. Please put any questions or comments you have in the chat. Let's begin by introducing our devoted leaders here. First up, Dr. Adrian Gardner, who is Executive Director of the AMPATH Consortium. Dr. Carol Wools-Kaloustian, who is the Executive Site Director for AMPATH Kenya. And Jackline, Njiru, the Director for the Legal Aid Center for Eldoret and the Amani shelter. And with that, I turn it over to you, Adrian.
Thanks so much, Teresa. Just want to say thank you to all of you really for being on the call today. You're here because you care about our patients, you care about our staff, and we are incredibly grateful to you for standing with us, particularly in this challenging time. So as Teresa sort of alluded to already, the goals of today are really to kind of provide some updates about how things are going with AMPATH. Obviously, everyone in global health has been affected this year by significant changes, including us at AMPATH. And as many of you know, the funding cuts have in particular affected HIV prevention works and programs, including the DREAMS program, which is a program that empowers adolescent girls and young women with HIV prevention sort of skills and life skills. Our family planning programs supporting orphans and vulnerable children in particular have been cut. But the AMPATH program in support of the Ministry of Health's HIV efforts are still going strong. So patients are still getting their medicines. We have this sort of reduced funding level that's relatively stable through March, what they're calling bridge funding, which you'll hear more about. That is still support from the U.S. government. And there are ongoing negotiations between the Kenyan government and the U.S. government in terms of these sort of bilateral agreements that are part of the America First strategy that you'll hear a little bit more about. There's still a tremendous amount of uncertainty around those and what those are going to look like and how ongoing support will be filtered down, to the frontline level. But we're hopeful, and we'll see how that sort of plays out over the next few years. So I think this is also sort of a moment of hope and opportunity for AMPATH in particular because of the design of our program and the model, and it is worth reiterating just sort of how the structure aligns itself with a sustainable sort of country-led model rather than sort of more typical sort of NGO models. So just to provide some overall context of what we're going to kind of narrow down on today, but as you know, the AMPATH program is now a global partnership serving 40 million people in 40 countries. And what began in Kenya 35 years ago is now seeing tremendous impact in Ghana and Mexico and Nepal as well. I recently had a chance to visit Nepal and see some of the wonderful work that's happening there. So it was really exciting to be able to sort of see that firsthand. But today's focus is again on Kenya because our newer partners in Ghana, Mexico, and Nepal really don't have support from the U.S. government like we do in Kenya, and this has been such a critical part of the HIV effort in Kenya. That's where the biggest gaps are right now. So again, just to sort of reiterate the model, I believe our model, of course, is really special, and as you all know, it's really led by in-country partners. You can see there the local institutions that are leading those efforts in each country. and then a growing number of institutions in the US, Canada, and Europe that make up what we call the AMPATH Consortium. That number continues to grow. As you can see, there are 17 institutions now, and we're in soon there'll be 18, and we're in discussions with another couple. So I think it's probably not too far off from hitting a round number of 20, which is a lot to manage, but I think is unique to the AMPATH model as well, that we can align multiple institutions working in a complementary way and still have an effective impact. So obviously, we're embedded within the public sector system, as I said, and not competing as an NGO, and focused on underserved populations that really cut across that tripartite mission of service, training, and research. So just again, sort of lay a groundwork for what's happening sort of at a global level. As you all know, PEPFAR has been incredibly successful. The President's Emergency Plan for AIDS Relief has been a very successful investment by the U.S. government in addressing HIV, the global pandemic of HIV, and it's credited with saving 25 million lives. But we can see that global health is really at a crossroads, and if you look at this chart here, you can see in 2025 a pretty steep decline in overall funding for global health, cut by about $10 million, which is largely attributable to the cut by the U.S. government in terms of what they've contributed. But unfortunately, we're seeing sort of the decrease by the U.S. government also followed by decreases by European countries in the UK and Germany, and sort of broad cuts in support for international organizations like the WHO that will have an impact for really across many countries. We are, at least there's some hope that the Global Fund last Friday, I think, was secured pledges of about 11 billion. That was short of their goal of 18 billion, but still a substantial amount. So it's not all gone away, and we're glad to see that the sort of countries are still committed, including the United States is committed to a substantial amount. Again, a decrease in their previous pledge, but still a substantial amount to the Global Fund, which addresses HIV, TB, and malaria specifically. So anyway, just to sort of provide a global context now, I'm going to turn it over to Kara and talk about the U.S. government changes and the impact on AMPATH Kenya in particular, and you'll sort of hear more from Jackie about the personal touches. So, Kara?
Hi, good evening, everyone. So, the timeline of the changes, if you've not heard this talk before, in January, the executive order was issued to freeze for a 90-day review period all USG international global health funding. This impacted the programs here to the tune of $16 million and affected 127,000 people with HIV, in addition to another 100,000 children that were in our OVC programs. We did receive a waiver, so we did not have to wait through the entire 90-day review period before we received funding, but there was a great deal of uncertainty. Despite this, care continued on a volunteer basis from our staff. And they were not guaranteed that they were going to get salaries in February. However, you all stepped up and allowed us to pay their salaries in February, which was a huge relief to all of us. Ultimately, the programs came back with cuts to family planning, HIV prevention services, and orphans and vulnerable children services. To compound some of the fiscal challenges of the site, in May 2025, there was a pause on all global subcontracts for research awards issued by the NIH. Since this is 90% of our research portfolio here, it also caused some confusion and a bit of chaos. We had to lay off 300 staff at that time. Some of them have returned with some new funding mechanisms available for international subawards, but we still have a lot of people that have not returned. We are currently in a bridge period for PEPFAR, as Adrian indicated. This goes on till March 2022. Next slide, please. So just to remind you, PEPFAR's had an incredible impact on HIV, preserving, as Adrian said, millions of lives, but also decreasing the incidence of HIV in the population and allowing more people to be HIV free. Modeling scenarios, if U.S. humanitarian aid ends between 20 and 25, we will see 4.1 million excess HIV-related deaths across 55 countries and see an estimated approximately 600,000 additional tuberculosis deaths across 79 countries. So this could be a huge global catastrophe. Next slide. We do, however, have some hope because the U.S. Global Health Strategy did come out in September 2025. It will proceed with bilateral agreements that are currently being negotiated between countries, and Kenya is in the midst of their negotiation. The goal is to advance American interests, save lives, and enable economic growth. We know that the 4 pillars of the bilateral agreement that's being negotiated in Kenya includes maintenance of commodities, maintenance of frontline healthcare providers, surveillance systems, and informatics systems. It looks like, as per the current negotiations, funding will remain the same in the first year of the bilateral contract, with step downs for subsequent years. The hope is that commodities will be one of the last things to go in this process. Next slide. So as Adrian pointed out, we have numerous programs. Many of them are not funded by the U.S. government in any way, but we've seen a severe impact, or there's potential for severe impact in our HIV programs. And certainly there's been severe impact in our orphans and vulnerable children programs. Those programs were predominantly funded by the U.S. government and now are completely defunded by the U.S. government. So the programs that are ongoing are purely donor funded from non-USG sources. In addition, our tuberculosis and malaria programs will be impacted. Our adolescent health program, which was predominantly for adolescents with HIV and prevention services for adolescents, is impacted. Informatics is impacted because the US government supported the HIV data systems within the country, and we are in the environment of emerging EMRs in Kenya. And so much like about 25, 30 years ago in the United States, we have many competing informatics programs, and it's unclear what will rise to the top, which makes it difficult to link data at the moment. On the positive note, there's more money going into our primary care initiatives, particularly our NCDs and chronic diseases, because we're looking at this as a mechanism for sustainability towards the future by incorporating HIV services and NCD services in chronic disease centers. This allows for continuity of care for people with diabetes and hypertension using some of the models that were created in the HIV program, and allows better sustainability by embedding our HIV program in the routine healthcare systems of the country. Next slide, please. So all of you made it possible for our HIV care programs to continue through the funding freeze. We had many programs fall apart around us, and we were able to maintain staff and keep clinics open. It's been possible to maintain 5,000 young women in the DREAMS program until their graduation in December who would have been abruptly released from that program. And it's also allowed us to maintain the Amani shelter and the Legal Advocacy Center for Eldoret, which Jackie will now talk about.
Thank you, Kara. Good evening and good afternoon, morning, depending on where you are. My name is Jackline Njiru, Kibaru. I'm the legal director of LACE. LACE is the Legal Aid Center for Eldoret. and I'm also the manager at Amani Shelter. So today I'll take you through the journey of LACE and Amani Shelter and what really LACE is all about. So LACE is a legal aid clinic that is situated in AMPATH. And the essence is to provide free legal aid services to patients of AMPATH, those that are living with HIV and AIDS, and also survivors of sexual and gender-based violence. We are situated right within the AMPATH Center, that is within the hospital setting, with the main aim of providing a one-stop shop kind of setting for our patients so that they don't have to really go out searching for services, and especially when they have legal issues. So the services that we offer at LACE are the legal advice and counsel. We do legal representation after assessment of cases and need for litigation. And we also offer alternative dispute resolution with a bias on mediation. And this is so that we're able to preserve issues where we have family having disputes. We need to preserve the family relationships. We also have trainings for our healthcare providers so that they're able to offer services within the human rights-based perspective, and they also do not violate the rights of patients, even as they offer the services. And we do also give student mentorship to law students from various universities. Next slide, please. So over the years, and since inception, LACE has had an opportunity to serve 17,883 people. This is both within and outside of AMPATH. We do receive patients from within AMPATH and from other places that AMPATH is situated. And of course, because of being there for this long, we also have collaborations with other organizations and other stakeholders who also send us clients. And as I've said, the issue is to enable clients to solve their legal disputes. And I would want us to have a mind journey. Imagine of a client, maybe a widow who has come to the hospital and has some legal issues. She's come for treatment, but is facing violations back at home, or is having some inheritance issues with the in-laws, comes to the hospital, and the nurse, upon maybe assessment, realizes there are more issues other than the medical issues that this client has come for. And upon maybe investigations, they realize this person is facing violations back at home. How is it safe to send that client with their legal problems out there and just address their legal issues? That is the essence of LACE being within the hospital setting, to ensure that once they are dealt with, they have their medical issues are addressed, then they are able to come in and have also their legal issues addressed. And this really promotes adherence to drugs because they get all their issues sorted from one station. We do collaborate with AMPATH, with the government, the judiciary, the prosecution offices, the probation offices, and other civil society organizations, because we realize legal issues cannot be addressed from one arm. We have to work with the government, we have to work with the judiciary to ensure expeditious dealings with our cases. If it is issues of children department, when we have these children who are vulnerable, we need to link them with the children department, either for repatriation or even for referral to us for purposes of giving them shelter and also giving them other services. Next slide, please. So allow me also to talk about our Amani shelter. The Amani shelter is a brainchild of Sarah Mamlin, who's a visionary person that we really respect. I believe in 2005, HIV was still a very major issue. And women mostly faced issues of stigma and were being chased away from their homes because of issues of HIV. And Sarah deemed it fit to establish Amani shelter. So initially, Amani shelter was specifically for women. And within the shelter, they would get their medication. They would be trained on how to on empowerment, economic empowerment, how to track their drugs, and in the process, how to adhere to their treatment. So, of course, over time, women were empowered, and the shelter transitions to now issues of addressing children. And currently, we have, though we are open to other people, the shelter mostly deals with issues of children. We currently have a number of 12 children in total. And the main aim of this shelter is just to ensure that the vulnerable and marginalized receive their medication, their nutrition needs are met, and where possible, through the journey of having them recuperate, the children get the education. Shelter initially was purely for HIV infected persons, but over time we've had survivors of sexual gender-based violence who need safe spaces as their cases are ongoing in court. So we do accommodate them, but on very temporary basis. Yeah, so since inception, we've had 705 women and children that have been sheltered within the Amani shelter. Next slide. Yeah, for LIS and Amani shelter, we need an annual budget of around 150,000 USD. And these monies go towards majorly the running of the operations, the normal annual operations of the shelters, which is including of food and education. Currently, the number of cases that we have at least are 60 clients. Those are the ongoing cases. Those that are still very active in court, though we still have walk-in clients each and every other day. So I wish to highlight maybe one or two cases that we have had to address or have successfully addressed at the shelter. We've had a situation where we had one of the children who had been facing issues at home, back at home. She's HIV positive, came to the shelter at 14 kgs. She's 17 years old. And through the shelter, she's been able to get her nutritional needs met. And as at now, she is weighing 25 kgs. So that has been quite a story. When she first came to the shelter, I was actually afraid to admit her because I thought maybe this is a case of someone who is, almost at the verge of dying. But just seeing the progress, the psychological support that they get from the staff from the shelter in terms of encouragement, the nutritional nourishment that they've been able to get from the shelter, that has been one of the highlights for me, especially this year. And for LIS, we've had lots of successful cases. A case in point where we can merge the LIS issues and shelter issues of a lady who came to the shelter because of sexual gender-based violence from the husband. And we were able to offer that lady a safe space for 1 year until the case was concluded. So LIS and the shelter has been a turning point for so many patients, both in AMPATH and out of AMPATH. And I would actually equate it to a lifeline for most of the patients. And with the support that we have had from the emergency funds, which I take this opportunity to thank everyone who's been involved, we have seen people's lives being restored. And this is something that I would wish that can be replicated in so many other places, and also can have an opportunity to just continue, so that every child is given an opportunity to just live in whatever big or small ways. We can do it together to just reclaim the lives of these people that we greatly serve. Thank you so much.
So, in order to address the changing environment for AMPATH Kenya, we had a strategic planning meeting in November of this year. And while we're still in the process of analyzing the findings, some of the key things, takeaway points that were that cut across many groups and discussions were number one, the need for better communication and integration of programs to allow better utilization of resources and communicate better the effectiveness of the programs that we have initiated. The other one is ensuring sustainability by integrating in the beginning with healthcare systems in the Ministry of Health, and supporting the integration of HIV into the routine health system in Kenya. And then the last was really to look at our donor portfolio and diversify it. To again start looking at resources within Kenya to support. We have many emerging companies that are now becoming donors, and then the general population that can donate to some activities such as LACE or the shelter. So trying to diversify where funding comes from and not being solely dependent on or greatly dependent on the US government for funding. In addition to looking at local donors, we're expanding our look at European donors for some of our programs. Next slide. What you can do to help us, as we always tell you, be a champion for global health within any sphere of influence in which you reside. Please continue to donate to AMPATH either through monthly giving or multi-year commitments to help us sustainably plan for this uncertain future. And just to note that the year-end match doubles your gift to AMPATH Operating and Emergency Funds through December 31st, and the link is right there for you to donate through. Next slide. Asante Sana, thank you very much for continuing to support us and help us to build a healthier, sorry, it's late here, healthier and more hopeful future for our patients, our colleagues, and the world.
Thank you. Really applaud the work that everyone is doing and that you on the call are contributing to in many ways. Kara, I don't know if you saw, I posted, Elias had a couple questions that I think we have a little bit of time for. The first is, how is AMPATH adapting its model to remain resilient in an increasingly unpredictable global health environment? The second, okay, sorry, go ahead.
Yeah, so I saw those questions and I thought I partially addressed them on the slide about our strategic planning meeting. Again, we're still in the process of adapting new strategy and integrating the input from our stakeholders on how best to move forward in the world in this changing funding environment. But we're in a much better, so remember, we started this program on a shoestring budget 25 years ago when we started our HIV program. You know, Joe and I and John were the ambulance driver, the pharmacist, the nurse, the physician, and everything else at that time. So we know how to deal with financial hardship, and we made it through then. And we have a much more resilient healthcare system in Kenya than we did at that point in time. We were what I would call an urgent care care system when we started. People received acute care for their malaria, their fevers. The most prolonged care we provided was for tuberculosis. And the idea of a chronic disease model just was not there 25 years ago. The concept and the structures to take care of chronic disease now exist in Kenya. They need help. They're not perfect, but they do exist now. So we're starting out at a better place than we were 25 years ago. And I think with ingenuity and more strategic planning, that we will successfully navigate this challenge. And one of the reasons we can is that we truly are a partnership, and don't behave like an NGO. So we rely on the people on the ground who are here, who are going to be here regardless of what the funding situation looks like.
Thank you. I just wanted to thank David, Mary, and Collins for your words of encouragement. They mean a lot to all of us. And, you know, AMPATH is known to not shy away from challenges, but in spite of them and because of them, it takes a lot of, as Kara said, ingenuity, creativity, and resilience. And we're prepared to bring those with you by our side. So thank you very much. I don't see any other questions. I'm sorry if I've missed anything. I think that concludes our conversation today and our update. Again, thank you so much for being with us shoulder to shoulder. And as we say, we go farther together. I'm seeing another comment. Thank you for the hope you're installing in people. Well, thank you all. And that concludes our call.